So we're just here to take a moment to consider treatment in and around the clavicle. Okay, so if we're going to talk about treating the clavicle, a lot of the movements that you'll see me use when I do this, and I'll do this in supine, knowing that it's somewhat hard to see what I'm doing to the clavicle itself, but you should get some idea, and I'll also do this in lateral to display the same concepts in both positions. But a lot of the movements that I'll utilize when I'm working in and around the clavicle, or if I have reason to believe that there's symptomatology that the patient reports that's related to the clavicle, what I'm going to consider is the SC joint and the AC joint. But not simply considering those, considering the soft tissues that connect to them. So the major connectors or the major players in and around the motion of the clavicle are going to be the trapezius. So the fact that it connects to the lateral third of the clavicle, or at least the anterior border of the clavicle, you're not going to get a lot of motion of the clavicle off the SCM, although it does connect to the medial portion of the clavicle. And then you're also going to consider the pectoralis major more than minor, but minor is going to play, but you can't really peel them apart. But what we want to do is just consider that those are the soft tissues that are going to be the major players in motion of the clavicle. And you'll see when people are working around the clavicle that they'll often work on that to untether the bone or some of the motion of the bone, right? So in a situation where the patient's in supine, I will often do a fair amount of my work in a seated position. So you'll see something such as, you can't see my arm, but same concept as contact as control, right? So wrapping and reinforcing holds, and I can palpate underneath the clavicle, wrapping around the top of it, and get directly at the SC joint if I want to, coming medial. If my thumb is big enough, I can track the vast majority of the clavicle, and I can just kind of elevate and depress. I can kind of come into more of a medial motion, right? So it's almost like I'm trying to roll the whole shoulder girdle around the body. I can palpate here, check how it comes around, right? Recognizing that I'll run into soft tissue approximation. So I'm going to bring the arm towards the thorax. At some point, the arm is going to run into the soft tissues of the thorax and alter the motion of the clavicle, right? So you'll see things like that, or I will do things like this to check what's going on. If I want, and that's more at the SC joint, and also because broad contact for multi-point discrimination, or get as much as you can touch if we're talking about palpation, I can, in a hold like this, I can assess a fair amount of tissue. My hand's going over top of the trapezius. I can use my eyes, so multisensory integration, keep your eyes and your hands on the prize. Right? I can see all of this, I can get an integrated sense of what's going on, so I can identify where I want to work more. If for some reason I think that more of the issue with the motion of the clavicle writ large or as a whole is with the pectoral tissue, I can come in here, right? So I've got the arm away, but I'm still using a wrapping and reinforcing hold, right? I can move into the lateral border of the pectoral. I can do a push-pull, so working on soft tissue perpendicular to fiber direction. I can push down, so I have that as an option. If I need to work on the trapezius for some reason, this is a bad angle for me. I can essentially take a kind of a pinch type hold and push the trapezius away from the clavicle or pull towards. I can do it. It doesn't seem to be particularly advantageous for me. So in a case like that, I would often stand, right? So now I can get a better angle with my palpatory hand or my active hand, right, to work perpendicular to fiber direction. So I've got those things going on. Should I feel the need to essentially create more motion of the upper limb, but realistically the clavicle itself, so some motion that would be determined at the SC joint across, I can do that in a seated position as I already essentially showed, but I have more freedom when I'm standing to do this. So you can see something like this, so I can just lift the clavicle. I can pull across, right? When I pull across, as I'm palpating with a thumb bar under the whole clavicle, I can also use the other hand, right, in a bit of a lifting motion, so I can essentially have two things going on at once. I can go more short lever or more medium lever. I can just lift the shoulder off the table should I need to. The SC joint, again, has more mobility than the AC joint, but for the AC joint, you're going to have very minimal motion, not just because of muscular ties, but also because of the ligamentous ties, primarily to the coracoid process. What you're going to look at for motion of the AC joint, if you need to create some motion, you're creating motion between the clavicle and the acromion, right? So essentially a larger portion of the scapula. You'd have to essentially stop the motion of the clavicle or minimize the motion of the clavicle and create motion of the scapula. So what I will often do is I'll hook behind the lateral portion of the clavicle and I'll move the arm, because as I'm moving the arm, I'm moving the scapula itself, or if I move the arm far enough, I'll move the scapula itself. So sometimes you'll have the up table hand behind, depending on what I need to do, right? Sometimes the down table hand will come behind, and this can be quite forceful, but this is something that you would see described by Dr. Still, essentially stabilizing the scapula, or you would often have people stand, he'd draw the arm across, up over the head, and back out, because as I'm making all of those motions, I'm getting the scapula to move. Because I hook behind the clavicle, I'm keeping the clavicle still, so that's relational motion. One thing moves, one thing stays still. So there's a lot of talking and a lot of moving here, and you may not see everything, which is why I'll have the patient in lateral. So I'll have you lay on your side facing that way. Okay, so here, the same idea, you'll see my hands come to the front of the clavicle, right? Depending on the situation and what I'm looking to palpate, if I need to get into the AC or the SC joint, I'll come further forward, elevation, right, off the arm itself, depression. So if I can really feel the SC joint itself. I can also feel the pectoral tissue. I don't get much information about the trapezius, right? So then what I would have to do is I'd have to come back up to the trapezius itself and elevate and depress on that tissue. From here, I can actually do a good job working perpendicular to fiber direction on the trapezius. So depending on the hold that I need to take, I can take that, I can work there. All right, I can use mixed leverage, so I can keep the arm still, or keep the bones still, move the trapezius itself. I can keep the trapezius still, move the bones underneath the trapezius, in this case, primarily the scapula and the clavicle. So I can work on the trapezius there. If I need to work on the pectoral tissue, I can do so here. Right? So I've shown this before. If I need to work on the SC joint here, it's a little bit more awkward because I need to bring it in whatever angle, and what's going to happen is almost no matter where I put my arms, I'm going to run into my arm. I'm going to run into the palpating hand or the fixed point hand with the patient's arm as the lever. So it becomes a little bit more awkward to work on the SC joint. But so that you get to see it, again, I can have my elevation, depression, I can drop forwards. Right? Now you'll see that the patient's body rolls, so I have to stabilize the patient's body if what I really want to do is create, again, that rotation across the body at the SC joint. So I can just use the weight at that point. Now the other thing that becomes very useful here, if you've got good body contact in a respectful way with the patient when they're on their side, you can do a pretty good job working on the AC joint here. So it's the same idea that I'm going to stabilize the clavicle, right? So sometimes I'll have to take a pinch right at that lateral end. Sometimes I can just use the heel of my hand against it. Either way, I need to stabilize it somehow. And I can get all those motions, plus some that weren't available to me, right? Like pulling the patient's arm behind their back on account of the fact that the table would get in the way, and I'm usually in standing position when they're on their back. But here, I can do quite powerful work at the AC joint, keeping in mind that the majority of the motion that I'm going to sense is going to be the arm itself and the scapula, not so much the AC joint itself, because it does have a lot of soft tissue ties. So you're talking about the pectoral muscles, you're talking about the deltoid on some level, you're talking about the trapezius on some level, you're also talking about the ligaments, primarily attaching to the coracoid process. So you're not going to get a lot of motion out of the AC joint. You're going to feel like you do because there's a lot of auxiliary motions, but realistically you can be quite forceful, quite powerful at the AC joint, should you need to be, in lateral position, because you get a lot of motions, right? This is why I talk about the body contact, because if I keep the patient free, nothing happens to the AC joint, I just roll the patient everywhere. So the body contact stabilizes them. So less stable means I need to make the patient more stable. And we got some kind of noise out of that was unintentional. I don't know if it was at the AC joint. Was that the AC joint? Was that out here, or was that somewhere else?
Somewhere else.
Somewhere else, okay. That's another thing about bodies when they make noise when you're moving them. The cracks and the pops, you will often believe that they happen where you're palpating, because if you're palpating in one spot, you have your hand on the lever, something goes pow or pop or snap, you will hear it, you think you feel it somewhere along that lever, so you think it's specifically where you've placed it, and sometimes it's not. So that's just a circumstantial opportunity for me to say, don't trust the pops, don't trust the noises, because they'll often happen anyways and they don't happen where you think they do. Either way, talking about the clavicle in supine and lateral allows us to highlight a lot of things, including working on soft tissues, perpendicular fiber direction, patient positioning. So less stable means I need to make the patient more stable. Contact is control for our holds. Relational motion for holding either a soft tissue or a bony tissue still and moving that tissue in relation to it. So all of these things are able to be demonstrated here in a fairly fast manner with me talking fairly quickly, I would assume. But best thing about the whole deal, again, it's on video, so pause and rewind.